Hello, everyone, and welcome to the December 2019 New Researcher webinar. I may sound like a familiar voice, and that is because I hope that I am to most of you. I am the former New Researcher webinar coordinator, and since the last webinar was presented, I have taken a position with Employment and Social Development Canada. And so Dan Smose, who is the voice that you heard just before me, has taken over, and I'm sure that he will do an amazing job, and I look forward to all the webinars that he organizes from here on in. So Dan, I hand it over to you.
Great. Okay, so yeah, I'm Dan Samosh. I'm a postdoc at U of T, as well as the Institute for Work and Health. I'm here right now at the Institute for Work and Health with Sabrina Imam and Kathy Padkapayeva, who are helping to coordinate all of this. And we're really excited for our next webinar, the one that we have going today, which is with Andrea Jones. So I'm gonna briefly introduce her, and then she'll talk about her research. We will end with a Q&A. We do have a Q&A option on your screen. You'll see it kind of along the bottom part of your Zoom window. If you can't type in questions in there, because sometimes in the past we have had issues, also feel free to type in the chat and ask your questions that way. So just to introduce Andrea, Andrea Jones recently received her PhD from the University of British Columbia, which is really exciting, so congratulations, Andrea. That's in population and public health. Her research interests include worker mental health, work disability policy, the effects of working conditions on health, and strategies to improve work outcomes for workers with chronic health conditions. So specifically today, Andrea is going to talk about the prevalence of medically diagnosed anxiety and depression disorders during the year before and the year after work-related musculoskeletal strain or sprain, as well as the impacts of pre-existing and new onset anxiety and depression disorders on return to work. So this research is pretty directly aligned with what CRWDP does, and I'm really excited to hear what Andrea has to say today. So I'm going to turn it over to you, Andrea.
Okay, hi everyone. Thanks so much, Dan and Pam, for the introduction, and for everyone listening, thanks for tuning in. So the work that I'm presenting today is from my PhD dissertation. Okay, so my work's on musculoskeletal conditions and mental disorders. So both of these two sets of health conditions are extremely common. According to the World Health Organization, somewhere between 1 in 3 and 1 in 5 people live with a painful and disabling musculoskeletal condition. Mental disorders are also very common, especially anxiety and depression. It's estimated that in Canada, 1 in 10 adults is affected by an anxiety or depression disorder in a given year. So in addition to being common, these two types of health conditions, they're also leading causes of global disability. In the most recent estimates of daily adjusted life years from the World Health Organization, musculoskeletal conditions ranked as the leading cause, and this was followed by mental and behavioral conditions. So, often we develop painful or disabling musculoskeletal conditions. One of the reasons that they can develop for a lot of reasons, but one of them is due to work. And if we focus in on work-related musculoskeletal conditions and injuries, the most common in British Columbia are strain and sprain. So work-related strain or sprain in British Columbia, in a given year, there's approximately 37,500 lost time accepted claims for this injury type, which is about a quarter to a fifth of all lost time claims. And this accounts in a given year for approximately $425 million in direct disability costs. So for my dissertation, I was interested particularly in looking at anxiety and depression among workers with lost time musculoskeletal injury. So this slide is kind of a summary of the main findings from my literature review. So having conducted a review of the existing research in this area, the main things that I found that were among workers who already have a work-related injury was that the prevalence of anxiety and depression was reported to be higher than it would be expected to be based on general population estimates. This was particularly true for depression, where the difference between in prevalence for the working population and the general population was quite large. For anxiety, the difference across most studies was not as large, but still elevated. Another major finding was that for depression, most of the studies suggested that the injury itself was a stimulus for new onset depression in these injured workers. But the evidence for anxiety was quite mixed. So some studies suggested that the injury was a stimulus for new onset anxiety, and some studies suggested that it wasn't. And for all of the existing studies that I did find, anxiety and depression, the timing of the onset was self-reported by the workers during the post-injury time period. This last finding is a little bit surprising for me. Studies that examine the impacts of anxiety and depression on return to work after a work physical injury. Not all of the studies I found focused on musculoskeletal injury, but most of them did. The evidence was very mixed, so you can certainly find some studies saying that depression is a risk factor for poor return to work after musculoskeletal injury. But there's other studies saying the opposite. And I did actually find 6 review articles that did examine this topic. And they all either concluded insufficient evidence or no impact. So I think the most comprehensive review article was the one done by Isles in 2008. And she concluded that among workers with non-chronic, non-specific occupational low back pain, that there was strong evidence that depression was not a risk factor for poor return to work, and moderate evidence that anxiety was not. So I found that quite surprising, and I thought that maybe some of those findings might be due to the limitations of past research. So there are quite a few potential mechanisms that could explain why anxiety and depression might impact return to work. So after a lost time musculoskeletal injury. And I just want to preface that not all of these mechanisms I'm going to list have necessarily been empirically proven, but they're things that have been suggested by authors in the literature. So the first one is increased pain. Both depression and anxiety are shown to amplify pain when there's a physical health issue present with pain related to it. They are both related to activity disruption. So this could be participation, things in your life that you typically do and enjoy, or it could be related to things that in a physical injury context that might be related to your physical recovery, like attending physiotherapy. There's some evidence that among injured workers, those that have a musculoskeletal injury, those that also have comorbid mental health conditions might be less resistant to treatment. So I think this particular study that I'm referencing looked at the effectiveness of a psychosocial intervention for pain catastrophizing. The next potential mechanism is anxiety and depression could affect your beliefs regarding return to work. So the primary, what really defines depression or anxiety disorders are the emotional symptoms. And so the strongest characteristics of depression are feelings of sadness or worthlessness or hopelessness. For anxiety, it's generally fear or worry. And I think you can see how all of those emotions could affect your belief of your ability to return to work or the likelihood that you will. People with depression and anxiety, in addition to their musculoskeletal injury, they might have a greater need for work accommodation. In the Canadian general working population, the proportion of people with depression and anxiety that report needing work accommodation is quite high. And I think that perhaps this need could be amplified when they are also experiencing a physical injury that's resulted in them having to go off work. And then the last potential mechanism I have listed here is stigmatization. So having a comorbid mental disorder, in addition to your physical injury, it could affect your interactions with key stakeholders in the return to work process, like your manager or your employer, healthcare professionals, or people working at the compensation board. So there's already a fair bit of research looking at mental health issues among people with work-related musculoskeletal injury, but I think there is a rationale for further research. If indeed anxiety and depression are related to a return to work after musculoskeletal injury, I think identifying that as a risk factor can help us design interventions, which can then in turn improve work disability outcomes. I think a lot of the prior research, there's some very common limitations across many of the studies. So this includes small clinical samples. Often the studies recruit from people that have already entered chronic work disability and tend to have more serious injuries like permanent impairment. Most of the studies have relied on self-reported mental symptoms as well as the timing of the symptoms. And this is typically measured after the injuries happen. So I think it could be perhaps be a little bit biased by maybe social desirability bias or recall bias. A lot of the prior research has had short follow-up, sometimes as short as 2 weeks or 1 month, or they just measure the time to the first return to work. And then in general, across the studies, there's been much more focus on depression than anxiety. Studies tend to look at men and women together instead of looking at the effects for men and women separately. There hasn't been much focus on the impacts of depression and anxiety on recurrence, and there's even less literature on potential interventions. So I had access to a large population data set that I thought could address some of the aforementioned limitations of past research. So my research objectives were to examine anxiety and depression disorders among workers with lost time, work-related upper extremity, or spine strain or sprain. So I wanted to look at the prevalence, timing, and risk factors for these disorders. I wanted to look at their impacts on sustained return to work, their impacts on more individual return to work events like entry to non-modified work from time loss, as well as the recurrence of time loss for people that have already returned to work. And then I wanted to look at differences between men and women for the above objectives. I also had a fifth research objective that I looked at that I don't think I'll have time to present on today unless I finish early and people are interested, but I also, for my dissertation, looked at the applicability of an instrumental variable method to research on the effects of anxiety treatment on paid disability days for people with a work-related musculoskeletal injury. All right, so to conduct this research, I used linked administrative data that I got from Population Data BC. So this included data sets from the Provincial Workers' Compensation Board and the Ministry of Health. So I used workers' compensation data to identify people with accepted claims for upper body strain or sprain. And I also used the workers' compensation data to determine their return to work outcomes. I used a combination of pharmaceutical dispensing data, hospitalization data, and physician billing data to identify people who had an anxiety or depression diagnoses from a physician or who were on anxiolytics or antidepressants. I also had access to a demographics file, and from across all of the data sets, I was able to identify a fair number of socio-demographic and other study variables. So my study cohort consisted of lost time claims in British Columbia for back or upper extremity strain or sprain for workers between the ages of 19 to 64 at the time of injury. For the study objectives that didn't look at return to work as an outcome, I had a study sample of just under 300,000 because I had a longer time range of 2000 to 2013. This study sample was 60% men. The majority of workers were between the ages to 30 and 59. So there were less younger workers and less older workers and a lot of middle-aged workers. Over half of the study sample had a prior accepted workers' compensation claim in the last 5 years. Somatic comorbidities were common for both women and men, but they were a bit more common in women. So women were more likely to have a high number of somatic comorbidities, and men were more likely to have a low number. Men were more likely to be high income than women, and there was definitely a difference in occupation across gender. So men were more likely to work in trades or manufacturing or utilities-based occupations, and women were more likely to work in sales or service or health occupations. For the study samples, for the study objectives that looked at return to work as an outcome, I had to use a shorter time period because the detailed return to work data has only been available since 2009. So I had a study sample of about 84,000 with a similar demographic distribution. All right, so I want to go over my case definitions for anxiety and depression that I used for this research because I think it is very meaningful to how we interpret the results. So we are looking at clinically treated anxiety and depression, which is maybe a little bit different from self-reported concurrent symptoms. So for anxiety, what I did was I identified anxiety health system contact events that a worker had during a time period. So I looked at diagnoses from hospitalizations, diagnoses associated with a physician visit, and then I also looked at use of medications recommended as first-line treatments for anxiety. So that includes anxiolytics or antidepressants. For depression, it was similar but specific to depression. So depression diagnoses associated with hospitalizations or physician visits, and also use of antidepressants. So I classified everyone in my study sample as having either none, anxiety only, depression only, or both. And in order to get, for example, in the category of having anxiety, you had to have at least one hospital diagnosis associated with anxiety. That was enough to rule you in. For physician visits, you had to actually have 2 physician visits with a diagnosis of anxiety within 365 days of each other. Or you had to have a physician visit associated with anxiety and also a relevant prescription within 365 days of each other. So the idea behind requiring 2 health system contact events was so that we could have a higher degree of certainty that the people classified as having anxiety or depression actually had those disorders. All right, so I'm gonna go over some methods and then jump into the results. So for the first study, which was primarily descriptive, I was looking at prevalence, timing, and risk factors. So I looked at the prevalence of anxiety and depression disorders in the year before injury, and then I compared it to the year after injury to infer the timing. And then I looked at a pretty wide host of socio-demographic injury, clinical and work-related risk factors, and I examined their associations with both prevalent disorders present in the year before injury, as well as new onset disorders that started in 3 months following injury in separate models using multinomial regression. So my second study was looking at the impact of anxiety and depression disorders on time to sustained return to work. So I looked at pre-existing disorders from the year before injury, as well as new onset disorders that happened after injury, but before sustained return to work. And I looked at those in separate models. My outcome was sustained return to work. So this was defined as the days from injury to the day that they returned to non-modified work and had no further wage loss or modified work days. So if you returned to work, but then had to go back off work, you didn't reach sustained return to work until you went back to non-modified work and stayed there. And I had a pretty wide range of socio-demographic, injury, clinical, and work confounders. For the last study, I focused on pre-existing and anxiety depression disorders, and I specifically wanted to look at, among people on time loss, how does having anxiety or depression affect your probability of transferring back to non-modified work? So the difference here is we're not looking at sustained return, we're just looking at the probability of return. And then I had a separate outcome, which was time loss recurrence. So this was looking at people that were back at work, but looking at the impacts of depression and anxiety on the probability of having to go back on time loss, so back to off work. I had 2 years of follow-up, and for the analysis I used an extension of the Cox regression model intended for recurrent events to account for the fact that people might have multiple time loss or quite messy return to work trajectories. All right, so moving on to the results. So I found that in the 1 year before injury, about 13% of men had anxiety or depression or both, and 29% of women had anxiety or depression or both. So I didn't have a good comparison group to say if this is elevated relative to the general population, but it is estimated that 1 in 10 Canadian adults have anxiety or a depression disorder in a given year. So 13% of men and 29% of women in my study sample, I think, is quite high. These are the results looking at the prevalence in the year before injury versus the year after injury, so that you can see that for all of the conditions looked at for both women and men, the prevalence in the year after injury was about 2 to 3% higher than the year before. So we do see a slight elevation, but it's not a large elevation, and this surprised me. I did, based on the existing research, expect to see a very large increase in the year after injury, especially for depression. And we don't see that here when we're looking at anxiety and depression using healthcare data and diagnoses from physicians. So the risk factors for anxiety and depression are outlined here. I did look at quite a few risk factors, so it's a lot of information to absorb, but risk factors that were common to both men and women included older age, lower income, physical comorbidity, other mental disorders that aren't depression or anxiety. So for example, something like substance abuse or schizophrenia, prior claims, and also health, social science, education, government, and occupations. Risk factors that were specific to men included having a multi-site injury, working for a large employer, and living in an urban area. And then one specific to women included having a dependent, living in a rural area, or being employed in a business occupation. So this table is for risk factors for pre-existing anxiety and disorders prevalent in the year before injury. I also examined risk factors for new onset anxiety and disorders that begin in the 3 months following injury. And the risk factors for the new onset were quite similar to the pre-existing, so I'm not going to present them separately. For the most part, the risk factors that I identify in this table, they are very similar and very much in line with the risk factors that have been identified in the literature for the general population. Okay, so moving on to the next study objective that looked at the impacts of depression and anxiety on the probability of sustained return to work. So this first slide is looking at people with pre-existing anxiety and depression disorders that were prevalent in the year before their musculoskeletal injury. So if we focus on the blue dots, which are for men, the comparison group is men with no depression and no anxiety in the year before their injury. And you can see that for among men, the anxiety only, the depression only, and the anxiety and depression groups were all significantly less likely to have sustained return to work than men in the none group. When we go over to look at women, which is the red dots, we see a similar pattern, except the effect sizes aren't as large, so the dots are closer to the value of 1, which is the reference group. And also for women, depression only, even though women with depression on average were less likely to have sustained return to work than women in the none group. This difference wasn't statistically significant, and the 95% confidence interval for women in depression did cross 1. So this slide here is actually the exact same findings of the last slide, but it's on a different scale that I think is maybe a bit more easy to understand if you're not used to thinking in terms of hazard ratios. So this is looking at, for each of the study groups, looking at the median number of days until sustained return to work. So for the men's none group, men with no anxiety or depression, the median time to sustained return to work was just over 30 days. For men with anxiety, it was in maybe just under 50 days. So men with anxiety took 2 weeks longer to reach sustained return to work than men with neither anxiety or depression. And then for men with depression only and men with anxiety and depression, we saw an excess of about 1 week. For women, when we compared women in the anxiety and depression groups to women in the none groups, they did have some excess wage loss days until sustained return to work, but the differences were very small. So women with anxiety only took 5 days longer than average than women with neither anxiety or depression. And then the differences were even smaller for women with depression only or anxiety and depression. So those last 2 slides were looking at pre-existing disorders in the year before injury. So now this next slide is focusing on new onset anxiety and depression. So the none group is people that had no anxiety or depression in the year before injury, and they had no healthcare events for anxiety or depression. Actually, yeah. So for this analysis, actually anxiety and depression were treated as they're allowed to vary over time. So the study sample was people that had no anxiety or depression in the year before injury. And then, for example, the anxiety group would be people who at some point between injury and before sustained return to work developed anxiety, and they met the case definition for anxiety. So you can see here that new onset anxiety and depression disorders they're strongly related to lower likelihood of sustained return to work compared to people who do not develop a new onset disorder. And one thing that's important to point out for this slide is that the effect sizes are much larger than the previous slides looking at pre-existing disorders. So we're seeing a very strong relationship there. All right, so now we're looking at the impacts of pre-existing anxiety and depression on the probability of time loss recurrence. So this is among workers who've had a work-related strain or sprain that's resulted in them having to take time off work, who did have a first return to work, so they are back at work, but now it's looking at the impacts of anxiety and depression on the probability of having to go back onto time loss. So you can see that for men, compared to the none group, that men with anxiety do have an increased probability of time loss after initial return to work, although the 95% confidence interval for men with anxiety does just barely cross 1. And then that men with anxiety and depression both had a higher probability of time loss compared to men with neither. For men, the depression was not associated with the probability of time loss recurrence. And then for women, we saw a very similar pattern. Okay, so as a summary of those findings, I think the main findings from what I've presented today is that at the time of injury, there is what appears to be a high prevalence of recent or current episodes of anxiety or depression. So to reiterate, 29% of women in the study sample met the case definition for anxiety or depression in the year before injury, and 13% of men met these case definitions. The injury did not appear to be a major stimulus for new onset clinically diagnosed disorders. In terms of impacts on sustained return to work, I found evidence that both pre-existing and new onset disorders were associated with lower probability of sustained return to work. So the findings were a little bit nuanced. For pre-existing disorders, anxiety, depression, and comorbid anxiety and depression were associated with lower probability for men. But for women, only anxiety and comorbid anxiety, but not depression, were associated with lower probability of sustained return to work. For new onset disorders, all of the mental health categories had lower probability of sustained return to work for both women and men. In regards to recurrence, the patterns for women and men were very similar in that anxiety only and comorbid anxiety and depression, but not depression, were risk factors for recurrence for both women and men. So for the discussion, I think one thing that might be important to think about this research is that I did have quite a long follow-up time, and I did analyze a few different return to work outcomes, so sustained return to work, as well as the risk for recurrence. And so the findings with this work aren't necessarily, they're not compatible with some of the previous null findings that have been reported by other studies. And I think possibly the way that return to work was measured might have contributed to that. In particular, the finding that anxiety and comorbid anxiety and depression are risk factors for time loss recurrence highlights the importance of kind of looking at a longer return to work trajectory, especially one that extends past the first return to work, if you're interested in understanding the full impacts of anxiety and return to work, anxiety and depression on return to work outcomes. Some possible limitations of the research. I don't think the administrative data in itself is a limitation, but it is good to think about how anxiety and depression are measured. So one thing in particular is that it only captures treated disorders. So it could be, the estimates of prevalence here could be underestimated, as well as it doesn't capture treated disorders, and it doesn't necessarily capture people who are, during the return to work period, experiencing what might be high levels of anxiety and depression that aren't necessarily enough to meet the criteria of a disorder or necessarily enough to go to see a healthcare professional. So as a result of that, both untreated disorders and maybe subclinical symptoms, workers with those would be captured in my none group, which could actually lead me to underestimate the effects of anxiety and depression on return to work. Another thing to think about for the limitations is the external generalizability. So my study sample was only people with accepted time loss claims. So the findings may not be generalizable for people who don't report their work-related injury, or for people with a musculoskeletal injury that aren't in the workers' compensation system. In addition, my injury sample was strains or sprains, and it was capturing all people with these types of injuries, including those that went back to work quite quickly. So this is very different from a study sample of people with chronic work impairment, chronic work disability, or permanent impairment. So I think that in particular could explain some differences between my findings and previous research. The gender differences, so there was some evidence that the impacts of anxiety and depression on return to work were stronger for men than for women, especially for the pre-existing disorders. This finding, it didn't really surprise me. When we look at the larger literature on, gender differences on the impacts of mental disorders on work disability, there is some literature suggesting that the impacts are greater for women, but these studies tend to be kind of based on smaller clinical samples and they might not be generalizable, but there is more recent epidemiological research looking at anxiety and depression in the general population and work disability and differences by gender. And the more recent epidemiological research is suggesting that anxiety and depressions are more strongly associated with work disability for men. So coming back to my study sample, why my anxiety and depression have a stronger impact on return to work for men after musculoskeletal injury than women. There's a couple possible mechanisms. One, for example, could be that men are reported to have higher occupational expectations. So I think if you combine that with something like symptoms of anxiety, which is fear or worry, the combination of those two things might result in a perfect storm, so to speak, which could result in later time to return to work, especially if you're having fear or worry about aspects or what will happen when you return to work. One thing that was a bit of a surprising finding in my study is that when I looked at the pre-existing disorders, there were larger impacts for anxiety than depression. So there was a larger number of excess wage loss days associated with anxiety than depression. And this surprised me a little bit because kind of in the broader disability research, depression typically ranks higher than anxiety in terms of being a driver of disability. So this was a bit surprising, and I don't particularly know why I saw it in my study. One possible reason is that it could be that the symptoms that are most strongly characteristic of anxiety, such as fear and worry in particular, might in particular negatively impact the return to work process, even more so than the symptoms characteristic of depression, such as sadness or hopelessness or worry. But that's just a hypothesis to explain my findings. That's definitely not something I've investigated directly. So in regards to policy, practice, and future research, I think some things to think about from these findings, the group of workers that had an anxiety or depression disorder, in addition to their work-related musculoskeletal injury, they were a large subgroup. So if there were to be interventions that could reduce the negative impacts of mental symptoms on return to work, if those were to exist, you could definitely impact a large number of the injured worker population, especially amongst those with strain or sprain. I found evidence that both pre-existing and new onset conditions were associated with poor return to work outcomes. And I think this actually has quite a bit of implications for policy and practice. I know in British Columbia, in order to have mental health services for a mental disorder covered by workers' compensation, the mental disorder needs to be accepted on the musculoskeletal claim. That's if you have a physical injury to receive mental treatment specifically for your mental disorder, the mental disorder has to be accepted on the claim, and to get the mental disorder accepted on the claim, the mental disorder has to have either resulted due to the physical injury or have been exacerbated by the physical injury. So for the pre-existing conditions in this study, I wasn't able to tell whether or not they were exacerbated by the physical injury, but they definitely weren't caused by it because they were pre-existing. But I think given that from the evidence here that pre-existing disorders do impact return to work outcomes, I think that's a rationale to include mental health services in a physical work injury context for pre-existing disorders, as well as new onset ones. The fact that anxiety and comorbid anxiety and depression were risk factors for time loss recurrence, I think this suggests that, if we could find mental health supports that would facilitate people with anxiety or depression disorders to return to work after a physical injury, that these should probably begin during the initial time loss phase, but also continue after return to work. The mechanisms that might have been causing people with the anxiety or depression, making it more difficult for them to initially return to work, whether it's increased pain or emotional symptoms, those probably don't automatically just go away completely once back at work. So if there were effective supports or treatment for these workers, I think these findings suggest that it may be beneficial for them to be ongoing. And then I think lastly, the evidence that the impacts of anxiety in particular on return to work were larger for men than for women suggests that if we do start to, as a part of future research, look at interventions to facilitate people with mental disorders return to work after physical injury, that consideration should be given to gender-sensitive approaches. Unfortunately, looking at the literature, there isn't a lot of research suggesting what these gender-sensitive approaches might be, so that's definitely an area that I think could use further work. Okay, so I'd like to thank my supervisor and my thesis committee, and also my sources of funding and support, which include the Partnership for Work Health and Safety, WorkSafe BC, the Center for Research on Work Disability Policy, the Bridge Program, and Population Data BC. And then all of the inferences, opinions, and conclusions that I've presented today are my own, and they don't necessarily reflect the opinions or policies of the data stewards, which is the governing bodies that I got the data from. And I think I'll wrap it up there, and hopefully we have some time for questions.
Yeah, thank you, Andrea. That was a really, really interesting presentation. I appreciate it, and I'm sure our attendees did as well. At this point, we will turn to question and answer. While we are waiting for questions, I can start with one for you, Andrea.
Yeah.
Just wondering, so you recently received your PhD, and you've conducted this research. I'm wondering what's next for you and for this sort of stream of research.
Oh, okay. Yeah, well, I've defended my PhD, but I'm handing in the revisions this Friday. So I'm not officially complete, but I am very close. Yeah, for the next steps, right now I'm working with the research group that I did my dissertation with. So I'm helping out with some projects looking at health and safety auditing in the construction industry, but that's not as closely directly related to this research that I presented. So for those that were here at the beginning, I did allude to a fourth study that I didn't present on, looking at using physician treatment practices as an instrumental variable to look at the effects of anxiety treatments on return to work for people with a musculoskeletal injury and an anxiety disorder. So that's a project that I'd like to carry a bit further and maybe extend to depression. But for the time being, it is my next steps are a bit up in the air.
Great. Well, thank you for sharing.
Yep.
And while we have a question here. So let's see. This is from Kathy. Kathy says, Andrea, thank you for the great presentation. Interesting results about gender differences in return to work. I'm wondering what types of mental health supports are generally provided, if any, in BC for this population, and what supports may be recommended for a sustained return to work. And final question there is, did you have a chance to look into this?
Right. Yeah, so I think, we can think about mental health. The sources for mental health services are largely, given that we're looking at an injured worker population, they could be within the compensation board. They could be through the public health system, or they could be through the private health system, which people typically pay for with their workplace benefits. So my research was largely, what I presented today, largely very much focused on the compensation system and what can they do to facilitate return to work. And so there are some mental health benefits available through the compensation system for all injured workers. So there is some access to return to work counseling, but that's very focused on return to work and isn't necessarily meant to treat a mental disorder. If you have a physical injury, there is some, in BC anyways, access to mental health services through the compensation system for mental disorders, but the mental disorder has to be accepted on the claim. And I'm not sure how often that happens. It wasn't something I was able to analyze. And then there's also access to treatments through the public health system. There's access to counseling from family physicians, as well as pharmaceutical treatment. But there's a lot of evidence that in Canada that mental health is extremely undertreated. So for example, most evidence-based counseling programs for anxiety or depression typically recommend around 12 sessions of counseling, whereas in British Columbia, family physicians can easily bill for up to 4 counseling sessions, but not more. So and then even then, a lot of family physicians, I think I think a lot of them aren't as well trained or offering counseling as much. But that last statement that I made is largely based on my conversations with people. But there is evidence that within the public healthcare system, anxiety and depression are quite undertreated. And then you can also access counseling through a private counselor, which you might be able to pay with your workplace benefits. But as you know, there might be like socioeconomic equality issues with that. Not everyone has workplace benefits to cover the costs of that. So that's what's there. I can't remember the full question, but under treatment of these disorders, there is a lot of evidence for in Canada. So I think it is like a potential area to target through policy.
Great. That's a very helpful answer, I think. And next we have a question from Jennifer. She asked, in your conclusions for both anxiety and depression, I note you spoke about workplace injury.
Mm-hmm.
This does also include any injury, correct?
Pardon me?
So Jennifer's asking, but does this also include any injury? And that the injury might create onset of anxiety and depression, making return to work longer.
Right. So my study sample was people with musculoskeletal strains or sprains. So my findings are very specific to them. And I found that the prevalence of pre-existing anxiety and depression, it was so high that I focused a lot of the analyses on that. But I did do one analysis looking at where I restricted the study sample to people with no anxiety or depression in the year before injury. And then I identified people who had a new onset disorder at some point between injury and sustained return to work. And those people definitely had, the people that developed the new onset disorder, it was definitely associated with lower probability of sustained return to work. So I do think that the new onset disorders are contributing. to poor return to work outcomes. I was surprised that the prevalence of new onset disorders following injury wasn't more elevated than what it was. Does that answer?
So I think so, and we'll give Jennifer the opportunity to type some more back as well if she has any follow-ups there. But just in case while we're waiting for that, there was a question from Sabrina about risk factors. One of your previous slides said that a risk factor for men was, it used the term multi-site. I was wondering what that means.
Yeah, so that was, go back to the slide. There we go. Yeah, so that was men with pre-existing anxiety or depression were more likely to have a multi-site injury. So they were more likely to have more than one physical diagnosis associated with the claim. So for example, a common example of a multi-site injury that popped up in the data a lot was like something like neck strain or sprain and concussion. So that might be something like, say, a traffic accident, or that could happen.
Okay, thank you. This is not a question. Laura, oh, there's actually a question here afterwards. But Laura says, thanks for sharing and congratulations, Andrea. And then what follows that is quick question. All the folks in your sample had specifically workplace injuries? Question.
Yes. Was that the question? They definitely, yeah. It was all, well, work related. So, I mean, if you work from home and you're covered by workers' compensation, that could still be work related. But yeah, work related workplace injuries, yes. So the study sample was definitely restricted to that. Yeah. And it was accepted claims for reported work-related injury.
Thank you. Oh, we have a few more questions popping up now all at once. We'll start with Tiffany. Tiffany asked, would we be able to get a copy of this PowerPoint presentation?
Yeah, I don't see why not. My email's at the bottom there, so if you're interested, you can shoot me an email.
And our next question is another one from Kathy. Kathy asked, I have another question. Are there any age differences in the prevalence of existing and new onset disorders? And any age differences in how these disorders are related to sustained return to work?
Okay. There was. So in the general population, the average age of onset for depression is quite young. I think it's, I can't remember the exact year, but it's in your teens or early 20s. And then the average onset for anxiety is a bit later. I think the median age is 30. But if you recall from my description of the study sample, over 70% of my study sample was between the ages of 30 to 59. So my study sample was a lot of people that were middle age. And by middle age, because the average age of onset for anxiety and depression is so young, I think that's why the pre-existing disorders were so prevalent. Because if you are going to experience one of these disorders in your lifetime, it's more likely that it'll start at an earlier part of your lifetime. So yeah, there were definitely, so people that were older were at less risk of a new onset disorder than they were of a prevalent one, if that makes sense. Because the less time you've lived, the more you've had less time to have accumulated past experiences of these disorders. So the younger you are, the more likely you are to have a new onset. So I do think one of the reasons why the pre-existing disorders were so prevalent in my study sample was because the study sample was largely middle-aged, and then the younger people were at the higher risk of new onset conditions.
Okay, thank you. Next, we have a question from Laura. So Laura said, can you address at all the literature around blame for injuries and how that plays into things?
Sorry, the literature around what injuries?
Literature around blame for injuries.
Bla-
So I think this
blame.
relates to stigma and blame.
Oh, yeah.
And then Laura followed that by saying, I'm thinking, for example, of some of the literature around the PGAP program, PGAP program.
Okay, I don't know if I'm familiar with PGAP, so if you do want to email anything about that to me, I'd be really interested. So there's definitely a lot of literature on blame and this like burden to prove, your health issues to health professionals or actors in the return to work process. So my analyses that I did in my research, is very epidemiological. So it was looking at in the injured worker population, do these associations exist? So I wasn't really able to narrow in on why they necessarily exist, just the fact that they do. But there's definitely a lot of more qualitative research looking at things like blame and burden of proof. And I can't imagine, especially for a work-related injury like strain or sprain, where there's no objective way to measure the severity of that type of injury or to prove how bad it might be. So I can imagine that's very difficult to deal with, and that having a mental disorder would maybe make that even harder, especially if you're prone to worry or sadness or hopelessness. So I do think that the two would exacerbate each other. So, but I definitely can't necessarily, it's a bit hard to tie my findings into there, but I would say that under the potential mechanisms that I listed at the very beginning, that blame could definitely fall in here, especially under maybe stigmatization. If it's known that someone has mental health issues, I think stigmatization could play a role in saying oh, they're off work not because of their physical injury. It's related to their their mental health problem. I'm not saying that that's actually what's happening, but I could say how people involved in the return to work process might have those sorts of perceptions. So I definitely think it could play into it, but I'm definitely not speaking out of my empirical findings here. This is more hypothesizing.
And so I think this might result in some more hypothesizing too, but Laura followed that up by saying, as an example, rather than blame on the injured worker, if people blame, let's say, the insurance company for the delayed recovery, if that means that they might recover more slowly.
Oh, if the injured, I hadn't thought about it from that angle. If the injured worker themselves blames the employer or the insurance company. Yeah, I can't necessarily say. I haven't really encountered that as much in my reading. No, yeah, I'll have to think about it.
What I can add to that, just from my own research in this area, it's not directly related, Laura, but there's a lot of research on trust in return to work and how it is incredibly important. So it's a bit of an extension, but if an employee does not trust their employer or the insurance company, parties that are involved in return to work, then that may likely influence the process.
Yeah, I do. I guess now, kind of thinking, now that I've had an extra 2 seconds, social support from one's supervisor does play a really important role in returning to work. So if a worker felt that they weren't getting, or felt that they weren't getting sufficient social support from their supervisor, or if in fact the supervisor just wasn't providing a lot of social support, that would definitely, I think, negatively impact return to work. And Whether or not that varies by mental health status, I can't say for sure.
And so we will wrap it up now, if that's okay with everyone. I'll just conclude that Jennifer did clarify her point from before, that she has also, in her own work, it seems, been dealing with people who might have workplace injuries, but also accidents and struggles unrelated to the workplace that then also interact with anxiety and depression. So her question was trying to situate your research within that work as well.
Okay.
But Andrea, thank you so much for speaking with us. I think everyone learned a lot from your sharing your research. And just so everyone is aware, we will be having another webinar in the new year. So please take a look at the CRWDP website because we will be advertising that soon. But otherwise, yeah, thank you to all of the attendees, to Sabrina Imam and Kathy Patkapayeva here who helped make all of this work. And Andrea, we really appreciate that you shared your research with us.
Thanks for having me. And if anyone does want to have follow-up with questions or ask the slides, I think my email should be on the screen at the bottom there.